Okay, hello everyone, and welcome to today's webinar. My name is Kimberly Flores, and I am a surrogate intake manager with ACRC Global. We are your partner in building families. We are a full service surrogacy and egg donation agency dedicated to supporting you throughout your journey to parenthood. I am very excited today to introduce our esteemed guest speaker, Dr. Tortoriello from Share Fertility Solutions. Doctor, hello. Thank you so much for joining us today.
Well, it's a pleasure, Kimberly. Thank you so much for inviting me. Look forward to
Of,
chatting with everyone.
of course. So today, we look forward to you sharing your expertise on the fertility field, just because we do understand that it can be very tricky for those, that are newly being introduced to all things fertility and addressing some of the most frequently asked questions. But if you would please do us a favor and start with introducing yourself, telling us a little bit about you.
Well, my name is Drew Tortoriello, and I am the medical director of Share Fertility Solutions in New York City. This is a practice that was initially started by Dr. Jeffrey Share, who was actually a pioneer in the field of reproductive endocrinology. He's been basically at the forefront of this scientific technique for the last 35 years. So I came to this practice about maybe 20 years ago, and we've grown a very fruitful and I think very, very well-esteemed practice here in New York City. Our niche, basically, in addition to be cutting edge with the technology, is we are still a hand-holding, very, very personable, and I think humanistically based practice, where the physicians have a very one-on-one relationship with the patients. We communicate with them a lot daily, personably and personally. And I think we have the right blend of the compassion and the technology that you need to get your most satisfying experience.
Which is very important. I would say, just from the outside looking in, I've never had to do any sort of fertility treatment myself, but I would hope that, the doctor that would be caring for me is as experienced on the science end of things, but still able to provide a personable experience to make me feel welcome and comfortable. So we
Yeah, I
appreciate
would
that.
I would agree with you. I'd feel the same way.
All right. So, doctor, first question we have for you. How long would you say that embryos are good to stay frozen for?
Well, as far as we know, indefinitely. I mean, basically, when embryos are frozen, and the current technology is such a rapid freezing that the interior aqueous contents of the embryo cells and the egg cells, when we freeze them, becomes a gel. And we call that technique vitrification. And that's the state-of-the-art technique for freezing embryos and eggs. And once that has occurred, those embryos or eggs are basically in suspended animation and remain safe and snug really for many, many, many years. I mean, there have been eggs and embryos that have been thawed after more than a decade that have come out of it wonderfully and made babies. So the short answer is we don't know how long they can stay frozen for, but odds are it's for several decades at the least.
That is so interesting and crazy to think that we have gotten science so advanced that, we can have, we don't know how long. Right now the answer is indefinite. That's
Yeah, I mean,
amazing.
years ago, the technology for freezing and thawing wasn't very good, and it was considered an experimental procedure. But because the technology now is so, I think, ironed out that it's no longer considered experimental for probably about the last 8 or 9 years, it's been standard of care, mainstream, and we do it very, very well. So we don't blink an eye nowadays if we have to freeze something.
Amazing. So it does give patients, that comfort in knowing they can prepare while they're younger and then maybe make their final decisions on family sizes and genders and things like that later down the line, which I think is great.
Absolutely.
Okay, next question for you. What would you say is the transfer success rate with embryos that have passed PGS testing versus those that were not PGT tested, excuse me?
If you PGT test an embryo and the embryo is chromosomally normal, on average, that embryo will make a baby about 60% of the time down the road when you transfer it. Some features affect that 60%. There's a little bit of wobble in that. If the embryo was a very highly graded embryo and is chromosomally normal, that embryo is more like 65, 70% chance to make a baby. If that embryo is chromosomally normal but a little bit less beautiful in its grading, it may drop down to 50% chance. So chromosomes matter the most, but there are other aspects to the embryo's morphology and likely its physiology that can affect whether or not it makes a baby. Those things tend to be age-related for the most part. If you have embryos that are not PGT tested, just embryos that grow to blastocyst and you have them frozen or you want to transfer them, the big question about whether or not they'll make a baby down the road is, well, is that embryo that looks good normal? Because chromosomes, although they're not everything, is the main thing. So the answer to that question is, well, what is the likelihood that this particular pretty looking blastocyst that's unscreened is actually chromosomally normal? And that's very age dependent because you can get a blastocyst from somebody who's 25 years old. You can get a blastocyst from somebody who's 45 years old. Obviously, the pregnancy rates with each one of these blastocysts is going to be widely different. And that's going to be very much dependent upon the prediction that this is normal or this is normal. So if you have a beautiful embryo when you're in your 20s, it's likely to be PGT normal, likely to make a baby, very high chance, 70%. If you're 45 with a blastocyst that looks pretty good, but it's untested, odds are it's going to be chromosomally abnormal, unfortunately, and the odds of it making a baby are probably not higher than 10%.
Got it. So it would be recommended if it's within means and everything for all embryos to be PGT tested just for safety guard reasoning.
Well, I mean, I'm not dogmatic about it. I don't insist that patients have to screen their embryos. And frankly, there are some places that I know that actually mandate that. The patient has to have the autonomy to make these choices. And I tell them
Right.
basically the pros and the cons of PGT. The pros basically are you really get to the heart of the matter. This embryo is abnormal. It's chromosomally abnormal. You know that from the beginning, and you're not going to spend your emotional capital and your financial capital on a subsequent transfer that may result in a negative or a miscarriage. So you kind of get your bad news up front rather than down the road where it may be more painful to endure. The cons are, well, it's not covered a lot of the time, and you're going to have to spend anywhere from $2,000 to $4,000 on PGT sometimes. And the other con is that you have a bit of a delay because if you have an embryo that you make fresh, you can transfer it fresh in the same cycle that you do IVF. But if you do PGT, you can't transfer fresh because you got to wait on the results to come in. And then next month, when the results come in, if you have a good result, then you can do a transfer. So I give them all of these little data points, and then they have to think about what's right for them.
Got it. Lots of choices there, definitely pros and cons to both.
Sure, sure.
So we're going to switch topics a little bit. We know a lot of our intended parents do opt for using a surrogate to carry their pregnancy, for different reasons, whether it be age or health or just personal preference. Would you offer any guidance when our parents are looking for surrogates, sort of prerequisites when they are looking at the different candidates that they're presented with?
Sure. I mean, when you're looking for a surrogate, you're basically thinking about, I want to have a healthy baby. So in order for me to have a healthy baby, I want to have a healthy woman to carry that baby. So ideally, you want somebody who is likely to proceed with a pregnancy that's going to be smooth and complication free. So you want somebody, ideally somebody who's younger, but we would work with women in from their mid 20s to their mid 40s. So, that's basically a rough guide about aging. Ideally, you want somebody who's got no medical problems whatsoever to contend with because you don't want to have a flare up or anything going wrong in the middle of a pregnancy. And ideally, you want somebody who's got a track record of having been pregnant before and having an uncomplicated, preferably vaginal and full-term delivery. If you have somebody who meets those criteria, odds are she's going to be a good surrogate.
Great key points there. I think it can be a little overwhelming, I would assume, on the intended parent. And you're given all of these profiles and you don't even know where to begin, especially if it's, a little bit newer information for you. So great to have a starting point of what you should be looking for. Thank you so
Sure.
much.
Sure.
And then on the opposite end of that, for our intended parents looking for an egg donor, would there be any specific prerequisites that you would recommend when choosing a candidate?
Sure. I mean, ideally, you want an egg donor who is young, on the young side. I usually say somebody ideally in their 20s, somebody in the range of 21 to 29. Why do you want that? Because they're likely to have a good number of eggs. They're likely to be healthy, and the quality of their eggs should be very good. So you're likely to get, anywhere, donor in their 20s, anywhere from 10 to 30 eggs. Average, I'd say, is probably about maybe 15 to 18 eggs. You want somebody who is healthy. So all of these potential egg donors need to be screened. So they need to be screened and found free of infectious diseases. They have to pass a drug screen. And probably the first and foremost thing you want to do, and you should never presume just because they're young, they've got a bounty of eggs. you need to screen them for their egg reserve. Because every now and then you'll get a 25-year-old woman who, unfortunately, you screen her egg reserve and her ovaries are acting considerably older than her age would suggest. So young, healthy, and document ahead of time before you give her the final go-ahead that she's going to have a good egg reserve.
Would these all be items that would be checked in a something like a screening process with the clinic? It would be recommended before the final okay to move forward?
Yeah, all of these things would be done essentially before we would accept the egg donor. The other thing I should mention is that there are women who from time to time want to use an egg donor that is what we call a directed egg donor, where they know the person, maybe the person's a family member or a good friend. In those particular instances, we're a little bit less stringent in terms of what we're looking for because the biological or familial connection takes somewhat of a precedence. So you would be really willing to get somewhat less eggs if there's a genetic linkage to you. But those particular cases are relatively few and far between.
Right. Thank you so much.
Sure.
Okay, and then would you recommend transferring two embryos at once? And if so, what would be some requirements that you would look at before moving forward with that, as well as risks versus transferring only the one?
Yeah, I think the number that you transfer depends greatly on the circumstance. But as a general rule of thumb, you want to be very circumspect in how many you transfer. You want to follow the ASRM guidelines, American Society for Reproductive Medicine guidelines, which are based on common sense and prioritizing the health of the woman and the pregnancy. But long story made a little bit shorter is if you have a chromosomally normal embryo, because that chromosomally normal embryo has such a good chance to make a baby all by itself, you put back one at a time. And there are some doctors who have done studies on this, and they've actually looked at the data between putting back one normal embryo at a time versus two normal embryos at a time. And what they found out basically is that all that really seems to do is increase the risk of twins without really increasing the overall, hey, I'm pregnant rate. And why exactly that is, I don't know, but there is basically standard of care these days that you should put back one chromosomally normal embryo at a time. If you're dealing with, unscreened embryos, you may have a little bit of wiggle room to put back more than one. Or if you're dealing with somebody, even with euploid embryos, maybe she's done 3 euploid embryo transfers and none of them have worked for whatever reason. Maybe there's a lining issue or there's other things in the uterus or other things on the table. Then you might consider to gradually bump up the number that you put back. But by and large, we do one embryo at a time. And actually, the insurance companies nowadays, for certain insurance companies, they place such a high priority on minimizing the multiple gestation rate that they will actually not reimburse the patient if the doctor puts back more than one without an exquisitely explained reason why you're doing so. So it's a very serious thing nowadays.
So you would say the risks are a little bit higher with carrying twins in this instance.
Twins on TV are cute and cuddly and wonderful. Twins in the real world are a very big burden on the woman when she's pregnant, but more importantly, they increase the risk of literally every possible pregnancy complication. Probably the most worrisome one is the risk of preterm labor, because it's way better to have one baby born at full term than have two babies born several weeks early and risk some preterm issues with the health of the baby.
Got it. So it sounds like with the scientific advances that we have, one is a pretty good guarantee if all things are taken into account, likely to end in a normal pregnancy. So there's no real need to transfer two unless you're looking for twins specifically.
Yeah, I mean, some people are looking for that, and I greatly discourage it. But again, patients have autonomy, and you have to inform them and consent them. But the safest thing is to put back one, and you're really not losing anything because the technology nowadays is so good with one that your success rates are still super high.
That's good to hear. Okay, and then jumping back to PGT testing, what would you say is I know you've touched a little bit on it, but maybe the greatest benefit to PGT testing embryos?
The greatest benefit, probably the greatest benefit is the reduction in the miscarriage rate because miscarriages are a very, very sad and traumatic thing to go through. And if you are only putting back chromosomally normal embryos, then the miscarriage rate drops from somewhere around, 25 or 30% down to about 5 to 8%.
Oh.
Because the number one reason for miscarriage is that the embryo is chromosomally abnormal. So if you remove that from the scene and only put back normal embryos, does a heck of a lot for minimizing your miscarriage rate. It also is good, I think, for allocating your time and your resources. What if you're in your 40s and you're concerned about your egg reserve and the amount of time that you're going to have a good egg reserve, a good egg quality, you don't necessarily want to do a transfer that should never have been done because the embryo was abnormal, you didn't know it. You want to maximize your time. You don't want to get caught up doing transfers that are going to take up your time and your resources. And you especially don't want to get caught up in a miscarriage, which, despite the grief and the pain of a miscarriage, sometimes miscarriages don't happen until you're 8 weeks, 12 weeks, 16 weeks pregnant, God forbid. And that is a long time of your life to spend and basically waste your time when you could have been focusing and doing more good for your fertility.
Right. And then I'm assuming timing afterwards with the healing as well. Who's to say that you're ready to jump right back into a cycle after a miscarriage as well?
Uh,
So
Absolutely. Nobody has a miscarriage, then the next day says, let's do another transfer like
try
today.
again. Yeah, no, that would that
You-
would be a little bit.
there's a lot of recuperation to go through.
Right. Okay, great. And then does Share Institute accept outside embryo transfers? So either embryos transferred from a different facility to your facility, and could transferring embryos from one facility to another cause any sort of damage to the embryos?
Good question. Unlike a lot of centers actually that refuse to accept embryos that are transferred over, we do accept embryos that are transferred over. We want to know a little bit about the embryos. Obviously, if I genuinely believe that they froze an embryo that is so poor in quality that it's got no benefit for you, then I'm not going to accept it. But most clinics are very savvy about this, and they'll freeze something which is of decent grade. And if that's what you worked hard to create and that's what you have, I'm not going to insist that in my center you start all over again and do all the extra work and all the extra money when you have something right now sitting in another location which could very well do the job for you. That doesn't seem fair to you, even if it means I'm not doing, everything from the beginning. If it gets you pregnant and I can help, I'm going to do it. So short answer is yes, we will accept quality embryos to be transferred over. Damage to the embryos, I don't think is a realistic concern. We have worked with several very reputable courier agencies. I've never had a problem. I mean, I think that there's a possibility that something in transit could theoretically happen, but I've been doing this for about 25 years. I've never seen an issue. It's been very safe and very well planned out.
To know in case we have any, intended parents that are looking to make the switch. Thank you so much.
Yeah.
Would you say that age affects male fertility, which is a side that I don't think is discussed very often? So many times people are focused on the female side of things.
In short, yes, it does. We know that the quality of the semen analysis goes down as men age, in their 20s and 30s and 40s. The count goes down, the motility goes down, the morphology will go down, and the percentage of sperm that show DNA breakage will go up on average. The thing to mention, however, is that the aging process affects males to a greatly lesser degree than it does to the eggs of the woman. So it would be wrong to say that the age has no effect on the male contribution. It certainly does. But because men make sperm fresh every single day, the aging process is way more forgiving on men than it is for women in general.
Okay. Would you say an embryo is quote unquote stronger when used closer to the date of fertilization versus if it had been frozen for a few months?
I would say in general, no. If you're going to have a problem with an embryo, you're going to have a problem with an embryo when you freeze it and when you thaw it out. Everything in between is suspended animation. So there's no real decline in quality. That's why I said before, you can probably have an embryo frozen for decades and it's not going to matter very much. So I don't think you're going to have a better embryo if you froze it on Monday and thaw it out on Wednesday than if you froze it on Monday and came back a year later. I think you probably get the exact same outcome.
That is good to know for those of us planning.
Sure.
Is it possible for two men to provide sperm sources, but with one donor's eggs?
It's absolutely possible to do that. We have a lot of male couples that want to have one egg donor that will produce, maybe somewhere between 20 to 30 eggs. And then we will allocate half of those eggs to the sperm from one male partner and allocate the other half to the second male partner. And I would say that's a fairly common thing.
Okay. What is the process for medical screening of surrogates, and what is included in this process?
Well, for medical screening for surrogates, there's a psychological screening, number one. She needs a thorough health screening, and that the health screening basically would entail looking at all of the infectious diseases that you can imagine, and then some. We look for drugs in her system, and she needs to have a thorough, well, and depending upon her age, she would need a mammogram. Obviously, she would need an up-to-date pap smear. But very importantly, she needs some sort of uterine cavity assessment to make sure that the inside of her uterus is about as pristine as you can get. We don't want to see any polyps or fibroids or scarring. So that is usually a hysteroscopy or what we call a saline sonogram, where we put a little bit of water into the space of the uterus and very gently distend it open and just take a look on the ultrasound, make sure there's nothing in there. So that's essentially I'd say the rundown for what we want to look for in a surrogate.
Which is good to know because again, unless I think you've been through it, you wouldn't really know. You just hear, "Oh, your surrogate has been screened," to know
Yeah.
kind of what's going on and what's being searched for and all of that. Okay, what is the embryo transfer process like? And are there any, I would say, crucial points for the embryo transfer cycle?
Well, the entire transfer cycle is crucial. So you want to do everything as well as you can do it. The embryo transfer process is basically preparing the uterine lining to be quote unquote receptive for the embryo. And there's no shortage of different protocols that you can employ to get the lining receptive. You can do a natural type transfer where you allow the woman to ovulate naturally, or you can facilitate ovulation and then transfer the embryo into her uterus about a week later, which is the natural receptivity sort of scenario where women who are trying to get pregnant every month would experience with their partner. But in general, we don't want to leave anything to chance when we do transfers in our patients. So we like to do a somewhat medicated protocol, which at the bare minimum is about 2 weeks of estrogen, often by pill. It can be oral medication 3 times per day. Some women actually, believe it or not, prefer an injectable estrogen, which is only twice a week. But you need to be exposed to estrogen for about a minimum of about 2 weeks. And then you need to have progesterone exposure. Again, this could be progesterone vaginally for 5 days. It could be progesterone injection for about 5 days. But after about 5 days of progesterone exposure, then you actually come in for the transfer. And the transfer basically it sounds like some big, medical procedure, but it's actually pretty straightforward, simple, painless, and easy. The woman comes in and she requires no sedation. We essentially use 2 catheters in the process, put a very small catheter, like a guide catheter, through the cervical opening that goes in just a little tiny bit into the uterus. And then we call in our embryologist who's got the embryo catheter, which is very thin and flexible, soft. And right at the tip of her catheter, there resides the embryo. And I very gently slide that embryo catheter through the guide catheter. And you can see the whole thing on the ultrasound because we're looking at everything on the sonogram as we're doing this. You can see the little embryo catheter very gently make its way right into the heart of the uterus, in the middle of the uterine cavity. And then we just, with a little syringe plunger, just squirt the embryo right into that space. And we can see that little flash of light kind of when it goes into the space of the uterus. Kind of a cool thing to see. So that's it. It's kind of like an insemination process for women out there who may have had inseminations, where you put a catheter into the uterus and you inject sperm into the uterus. This is putting a catheter into the uterus and injecting an embryo into the uterus. And I would recommend that on the day of the transfer, the woman goes home, rests and relaxes that whole day, takes it easy, and then gradually builds up her activity in the few days thereafter.
Would you recommend something like a 24-hour versus 48-hour bed rest post embryo transfer?
I don't think it's needed. And there was actually a study done not too long ago that showed that they looked at women who got up immediately after an embryo transfer and kind of resumed basically fairly normal activity versus women that, laid down for about a day. The women that got up actually did just as well, if not a bit better. So I don't think you need to do bed rest, really. I think it's not a bad idea after you have the transfer to go home and just relax, just have a calm, peaceful, afternoon or evening sitting watching a movie or TV, just to sort of de-stress and feel good. And thereafter, I think you can do pretty normal activity as long as you're not tachycardic with a rapid pulse or sweating or dehydrated. I think you can do pretty much regular activity after that. If you think about it in the real world out there, when people in the real world are getting pregnant, they're not thinking to themselves, "Hey, I think there's an embryo about to land in my uterus. I better sit down and
Just stay in bed.
stay in bed."
Right, right.
They go to work, they go to the movies, they go for a run. So, the old days of telling women to lay flat for like 3 days we don't do that anymore.
That's good to know. Would you say that there's any frequently reported like side effects or anything after the embryo transfer, like cramping or anything like that?
Sometimes women will report a little bit of cramping. It's possible. A lot of women get cramping merely from the progesterone that they're using, especially if you use vaginal progesterone. A lot of women will say that makes me cramp a little bit. But, when you use a very soft, smooth catheter and a gentle technique, cramping is minimal to none. So most women aren't even aware. I have to like actually show them what I'm doing because they don't feel anything.
It's happening. It happened.
Yeah, exactly. Yeah. A lot of them don't know it. Oh, it's done? You're done?
Yeah.
Yeah, I'm done.
Interesting. Okay. And then how long, if you are using a surrogate, would you say that the surrogate would be monitored at either your IVF clinic or something like an outside facility from start of medications to the transfer?
Okay, well, here's how it goes. You do a transfer, you get your first blood pregnancy test done roughly about 8 days later. If it's positive, God willing, you get another one 2 days later. And we want to see a trend where the beta HCG level doubles or comes pretty darn close to doubling. If it's kind of like almost there, but not quite, we may do a few more blood tests in the days thereafter. But usually we get a good rise and then we say, great. And the next move is to get seen 2 weeks later for your first OB sonogram. And that's around 6 weeks of pregnancy. We're looking for a little tiny sac in the uterus with a little fetal pole and a little heartbeat, little heart activity. Then you come back about 2 weeks later when you're about 8 weeks pregnant. And then we do another ultrasound and we look for growth of the embryo and we want to see a more rapid heartbeat. And if we see that, we get a good 8-week obstetrical ultrasound, then we'll say, okay, at this point now, you should make your way over to an OBGYN. And, as far as I'm concerned, they can see the OBGYN the very next day if they want to. But usually we say somewhere between 1 to 2 weeks later. So basically, I'll follow them up until 8 weeks and then thereafter kind of be in the wings while they are looking for their OB. And I get more involved if they need me to get more involved, but usually it's about 8 weeks.
Good to know. Okay. And then would you recommend that intended parents look for experienced egg donors or a first timer is something that you would be okay with if they are choosing to use an egg donor?
I think if you have everything being equal, two young, healthy women with superb egg reserve, but one has donated before and has a track record where she made special, egg number is important, but if those eggs translate into chromosomally normal embryos or a pregnancy, I would pick the so-called experienced or proven donor over the first timer. Now, sometimes first timers, everyone's got to have a first time, so it's not something which is a negative. And especially if you see somebody who hasn't donated before, but something about her really appeals to you and you think she just has a wonderful personal statement, you really want to work with her over a quote unquote proven donor. I don't have a problem with that if everything else lines up because usually young, healthy women do great. But if you're kind of ambivalent, this one or that one, then take the proven donor.
Right. You kind of know what you're getting beforehand.
Yeah.
Okay. And then would you have any suggestions for parents who are at the very beginning of their IVF and parenthood journey?
Well, if you already know that you're beginning your IVF process, by that point, it means you've seen a reproductive endocrinologist, you've been thoroughly evaluated, and together you've determined that IVF is the right way to go. So you're already a long way into it. I mean, I think basically if that's you, then what I think you should know is that A, you're not alone. Unfortunately, it seems like fertility is becoming more and more of an epidemic as time goes by, so you're in very good company. But the very good news is that every year we get better and better at what we do and are more able to help people that have fertility problems. So you're in good company though, but you have good friends that are willing to help you and give you the success that you need. For people who have not yet even gotten evaluated and they're sitting at home saying, we've been trying for a while and it's not working, then you should see somebody like me. You should have that beginning chat, even if it's just to reassure you and say, I don't think you need any testing, it's too soon, or let's do some tests, everything looks good. Don't worry about it. Keep trying for a little while longer. Sometimes it's just good to get rid of that nagging little doubt in the back of your head to think, well, this is pretty routine and I'm going to keep trying for a little while. And then you take a little sigh of relief and you keep moving forward. And I guess that's basically what I would say. I would say don't be afraid to ask questions. Don't be afraid to see somebody like me and get your questions answered and get all the options laid out in front of you because that will empower you. And when you are empowered, you feel good. You feel better. You don't feel
Right.
scared anymore. You feel like you got you got some control over this, and that's a good way to feel.
Right. And I think there is a great positive to shedding a little bit of light to, just the entire fertility world with, even things like this, or just having open discussions, because most people don't know that they need IVF until they start trying and then realize that they're having a little bit of trouble or not getting pregnant as quickly as their friends. So I appreciate, you making the statement of you're not alone, because there's so many people I believe that struggle with IVF, and
Yeah,
it's very hidden in the shadows, kept, close to the chest. So I think bringing light to such a sensitive topic just helps people not feel so alone in everything.
absolutely. Absolutely. I mean, I think for every person who does IVF, there is probably one or two that need IVF, but don't feel comfortable looking into it or have, sadly, they have insurance issues or financial issues when they shouldn't have. And there's ways to, there's creative ways to get around that usually. Yeah, so I agree with you. You should be very, very open to talking to people like me. And there's actually a lot of very good support agencies that are out there too. Resolve is one of them, and you can find other people to chat with and feel like, hey, I'm really not alone.
Right. And we are offering some of those benefits today. If you scan the little QR code that is here on my screen, you can schedule
Nice
a free.
segue.
Always got a segue.
That was good.
You get a free consultation with us here at ACRC Global as your concierge to fertility, surrogacy, egg donation. Dr. Tortoriello is also offering consultations with his office. And of course, if you registered for this webinar, and I can jump back to that screen if you have not had a chance to do so just yet, make sure you scan our QR code so you can go ahead and enter for a chance to win a $500 credit. Oh, excuse me. If you register, you automatically get a $500 credit for our agency. And if you are the winner that Doctor chooses today, an additional $1,000 credit for our agency services. The winner will also receive a 25% discount on services with Share Fertility Solutions not covered by insurance. So very, very important there. And then we do have an audience question for you, Doctor. Would you say something like fibroids or PCOS would affect the quality of an embryo?
Quality of an embryo.
Mhm.
Fibroids would not affect the quality of an embryo. Fibroids might affect the ability of that embryo to actually implant and make a baby, depending upon how big they are, but more importantly, where they are located. A lot of women have fibroids, and most of the time, we don't make a big to-do about fibroids unless one of two reasons. Reason number one is the woman's quality of life is low because she's having symptoms like bleeding or pain or what have you. Or more commonly, if the fibroid is in a location where the embryo might want to implant but could not because the fibroid is there, i.e., in the space of the uterine cavity. So if it's there and you find it, you should remove it and then do your transfer. In terms of PCO syndrome years ago used to be considered a risk factor for poor egg quality. Doctors have since found out, essentially through doing IVF, that PCO syndrome women don't really make bad eggs over and above what their age would suggest. So you don't make bad eggs just because you have PCO syndrome, as far as we can tell. If anything, you make more eggs, and you would probably be more likely to get a normal embryo out of one IVF cycle than somebody who's your own age but doesn't have PCO syndrome, because they'll make 10 eggs and you'll make 20 eggs. So I don't consider PCO syndrome a risk for bad embryo quality. PCO syndrome is just something you need to be careful about when you do IVF, because you don't want the woman to have too vigorous of response, because then she's not going to feel comfortable after the egg retrieval. She's going to feel very bloated and miserable. So you need a good reproductive endocrinologist to monitor you carefully and pick the right dosages of medication so you get a good response, but not a crazy good response.
Thank you so much for that.
Sure.
Okay, and that concludes today's webinar. Doctor, again, thank you so much for joining us. I'm going to go ahead and leave this on our screen here for everyone to note. This is how you contact us over with ACRC. Doctor, would you mind giving us your email one more time if someone is interested in scheduling a consultation with you?
It's drew.tortoriello@shareinstitute.com.
Perfect. And of course, if anyone did not catch that, feel free to reach out to us, and we can also go ahead and provide you with Dr. Tortoriello's direct contact information as well. So I think just to wrap this up now, I will go ahead and place in our chat all of our entries. Oh, let me see. So sorry. There's more questions here. So sorry. One second.
Sure.
Oh, I did miss another question. I'm so sorry. Are the risks the same when carrying twins, conceiving naturally versus using IVF and a surrogate?
Well, twins are twins. And basically, your risk of twins, whether you conceive them naturally, whether you conceive them via a transfer, whether it's one embryo that split or two embryos that became fraternal twins, the risks are basically the same. So you can expect the same increase in preterm delivery and, there may be a slight increase in preterm delivery in IVF babies, but we don't know if that's due to the sort of the stimulation medication that the IVF patient has done. In the case of a surrogate, there's no stimulation. There's basically just uterine preparation. So I think you could basically expect the same outcomes.
No. Do you have any cautionary tales to share from your experience over the years?
Well, that's kind of a broad question. I don't know what that means.
Anything that you've seen, I guess, that maybe someone did against your advice or chose to do, maybe, like you said, out of their own autonomy that you saw maybe go sideways? Anything interesting you've seen in your field?
Uh, I think, the thing that comes to mind is that I've had people that I've warned them putting back more than one. They may get twins, they may get, and I had a patient who, she really, really wanted to put back two, and she made a compelling argument that if she didn't get pregnant with the one, then she didn't have enough resources to do another one, and she was leaving the country, and it was this, and it was that, and it was okay. So I thoroughly informed and thoroughly consented her, and I put back two, and one of them split. So she wound up having
Wow.
identical twins along with another one for triplets.
Oh, wow.
And that's a cautionary tale, I guess, that you never know. You may say to yourself, it will never happen to me, and then it will happen to you.
And those are the ones that it ends up happening to.
Yeah.
Well, I'm sure she was truly happy with her three babies. I mean, she definitely got her money's worth, right? One
She
try and three children.
she definitely did get her money's worth, actually. And I think she delivered nearly full term, which was amazing.
Oh, wow. Well, it worked out for her.
Yeah. But
But not recommended.
she sent me a lot of photos during pregnancy where she was feeling very uncomfortable to prove it, to put a little smile on my face saying I was right about it. But
All you
she's,
could say was congratulations.
yeah, but she was very happy in the end. So that's all that mattered.
But definitely not recommended. We're sticking to the one if at all possible.
Yeah.
Thank you so much again, Dr. Tortoriello, for your time and your expertise. We really appreciate it, and we look forward to getting more intended parents your way and working together in the future.
Oh, it was great. Thank you so much for having me here today. It was lovely to chat with everybody.
Of course. Thank you so much. And to everyone that joined us, again, our contact information is on the shared screen here. If you're interested, you are welcome to scan the QR code if you would like a consultation with us. And you have a good rest of your evening, Dr. Tortoriello.
You too, everybody. Have a great night.
Thank you. Goodbye, everyone.
Bye bye.